All right. So good afternoon, everyone, and welcome. We're really excited for today's webinar, and the Schlegel UW Research Institute for Aging and the Ontario Centres for Learning, Research and Innovation on Long-Term Care are thrilled to host today's session on navigating moral distress in long-term care. My name is Katrina Street. I'm one of the education managers at the Ontario CLRI, hosted at the RIA. And alongside me joining, we have Sarah List, who is helping to support today as well. And really, we're on a call. We're really excited and honored to be joined by both Kate Dupuis, who is a Schlegel Innovation Leader and
Katrina, sorry, I think you got muted there.
There we go. I'll kind of backtrack and say that we're really honored to be joined by Kate Dupuis, who's a Schlegel Innovation Leader in Arts and Aging, and Jane Kuepfer, who's a Schlegel Specialist in Spirituality and Aging. And together they're going to be sharing their highlights from their work on this critical issue on moral distress, including some of the key takeaways from the first ever Canadian Moral Distress and Long-Term Care think tank. We will be recording the session today, so if you have fellow colleagues who were not able to attend, we will be sharing that recording following the session. So again, thank you all for joining us, and I will pass it over to Jane to lead us off. Jane, you're muted.
Thank you. And welcome, everyone. Thanks for joining us today. We imagine that we have gathered here people who work in all aspects of long-term care, both leadership and team members, as well as others interested in this topic. So why are we doing this webinar? Kate and I, as researchers who also spend time in long-term care ourselves, recognize what a unique and important workplace long-term care is. It's a place that's also home for residents. It's a place of long-term relationships where workers and residents grow attached like an extended family. It's a place that attracts people with big hearts to work, a place of love, loss, and emotion, where our hearts and our values are tied into our daily life and work. And it's also a place that is structured and regulated, and some things are beyond our control. So at the same time as it's a meaningful place to work, it's also a hard place to work. And sometimes people leave because it gets too hard on our hearts. So we're doing this webinar because we want those who are cut out for this meaningful work, those with big hearts, to be well supported and able to thrive in it. We know that understanding the stressors, as well as understanding what makes work good and life-giving, will help people to both want to and be able to invest themselves in this work long-term. But as we begin, we want to acknowledge the land. So the Ontario CLRI acknowledges that we live and work on Indigenous land. The Schlegel UW Research Institute for Aging acknowledges that we're on the traditional territory of the Attawandaron, Anishinaabe, and Haudenosaunee peoples. The RIA is situated on the Haldimand Tract, the land promised to the Six Nations that includes 6 miles on each side of the Grand River. Our agenda today is to look at moral distress and moral injury in the context of long-term care, to share some current research, and to talk about strategies to support staff and leadership. And we'll finish off with some ways to get involved. I'm going to turn it over to Kate to get us started.
Thank you so much, Jane, and thank you to the CLRIs for supporting this work today. We wanted to set the stage a little bit for why we're having this conversation. The terms moral distress and moral injury may be familiar to you, they may be new, but the important thing to remember is that they are not necessarily new to the sector of long-term care. Even prior to the onset of the COVID-19 pandemic, nearly 5 years ago now, we knew that there were some challenges associated with the particular workplace. Jane has already mentioned, the regulations. I heard once in a presentation at a conference that long-term care here in Ontario is only the second most regulated workplace after nuclear power. And I'm sure those of you who work in this space and have been working with, inspections may agree with that. Individuals are often short on time. There can be short staffing in these spaces. We knew prior to the pandemic there were relatively high rates of burnout and stress, people leaving the sector with high attrition rates. And this was something that the sector as a whole, scientists, clinicians, people like Jane and I, who are a little bit of both, were already grappling with even prior to the onset of COVID. Okay. And Jane is turning the slides for us. So if I'm a little slow to move to the next one, or you hear me say, okay, Jane, that's why that's happening. We were both, as Schlegel UW Research Institute for Aging researchers, we were, of course, both pausing all of our work at the beginning of COVID, and as were many of our colleagues across the country. But, we're learning still from those folks on the ground within the spaces and learning from our colleagues who are also sharing with us what was happening. So during the COVID-19 pandemic, we've heard, fear for safety of your own self. At the beginning, we didn't have PPE. We didn't know what was happening. Fear for our residents who were so disproportionately impacted by the disease itself. Fear for coworkers who may also be getting sick. Fear for loved ones. So folks having to come home to their family members, maybe disrobing in the garage, hopping in the shower first, staying isolated from family and friends, maybe renting a hotel, maybe staying at a friend's house so that they wouldn't bring things home to their family. It was an incredibly high pressure situation, made probably a little bit worse by the fact that there were things changing every single day, right? As humans, we're always looking for patterns, we're always looking for some level of stability, and that just was not possible in this particular highly regulated workplace where ministry directives were changing constantly. We also had, of course, very vulnerable populations, very high death toll. Even prior to COVID, we had outbreaks in our homes, but now we were getting really this spotlight on the sector and such incredibly negative media coverage that was absolutely missing the beautiful work, the connections that each of you were engaging in every single day with your colleagues, with leadership, with the residents, even, virtually through family and friends, trying to connect people to their loved ones during this difficult time. Unfortunately, the media coverage did not highlight that. It was typically such a negative perspective that was being shared very broadly with the general population. We know that folks, under ministry regulations may have had to move down to only working in one home. Unlike in British Columbia, here in Ontario, the government did not necessarily provide additional financial supports for people who had lost those extra days. There were pay inequities experienced. Different individuals working in different roles were given boosts or pandemic pay bumps, and then those boosts maybe were taken away from some people, but not others. And again, that was highly publicized and people knew that. So you may have been working shoulder to shoulder with a colleague and you knew in your heart every single day they're making $40, $50 more a shift than I am, but we're doing the same work. This doesn't make any sense to me. And you were being called upon to provide a high level of care to people who need a high level of care, right? That's why we have our residents are in our homes, because they are requiring such a high level of care, but we had such limited resources, okay? And people said to us, I worry about COVID-19 constantly. I worry about the residents feeling lonely, feeling anxious, feeling isolated and depressed. Worry if we're doing enough to meet their needs. So this comment was shared with me from a survey participant who had replied to a survey we had sent out in late 2020, early 2021. And that's really sort of what started to germinate this idea for us of these individuals, while of course, folks working in the space were somewhat worried for themselves, they were so concerned for their residents. And it speaks to that emotional intimacy of the work, because these aren't just people you've met, like in an acute care setting for a short period of time. These are people you may have known for weeks, months, or even years. Okay.
So what is moral distress? What are we talking about? A couple of definitions that we found helpful. An original basic definition from back in 1984, moral distress arises when one knows the right thing to do, but institutional constraints make it nearly impossible to pursue the right course of action. And a more recent description from Tyler Vanderweel. Moral distress is distress that arises from a personal experience that disrupts or threatens one's sense of the goodness of oneself, of others, of institutions, or of what are understood to be higher powers. So moral distress hurts your heart. In the midst of trying to do good, and because you want to do good, you feel bad. Because for whatever reason, time constraints, rules, infection protocol being stretched too thin, you don't feel good about your work, about yourself, your team, your organization, even life itself or the God you pray to. You are morally distressed. And this can feel confusing, destabilizing, frightening. It feels terrible to feel bad about yourself and your work when what you want most of all is to be doing good. Many people feel alone in moral distress because feelings of shame and guilt are part of the experience. And people keep that to themselves, feeling badly and feeling alone. So I want to stop right there to just normalize these feelings and address that sense of shame. What I really want you to hear is that you feel bad in these situations because you are good. You have a big heart and you need to feel good about the work that you're doing. So it's distressing when you don't. When moral distress continues, it can injure you. Symptoms of being injured by this distress are feelings of persistent guilt and shame, anger and betrayal, feelings of worthlessness, helplessness, powerlessness, a loss of trust, self-isolation, reduced empathy, and negative beliefs about yourself. Moral distress is demoralizing. It can lead to PTSD, to struggles with anxiety and depression. It's a soul wound. In our recent research, we found that, though, as Kate said, moral distress isn't a new idea, over half of long-term care workers hadn't heard of these terms. The pandemic amplified the experience of moral distress in long-term care. And so we wanted to offer this webinar since, although the experience of the pandemic is now kind of in the past, people still have unaddressed feelings, and it really helps to know that there's a name for them, and it's something that other people feel too.
Thank you, Jane. So, we do a lot of incredible work at the RIA, and sometimes we work in our silos. And this has been an incredible opportunity for me to collaborate with Jane and to work very closely together. Jane is a psychotherapist, I'm a psychologist, and so it really made sense for us to come together in this. What we wanted to do is paint a little bit of a picture, a little bit of a journey, in case you're wondering, how do researchers come to these types of topics, for how we came together to be in this space and to be able to offer this opportunity to connect with all of you today. So as I had mentioned earlier, early on in the pandemic, Katrina mentioned I am the Schlegel Innovation Leader in Arts and Aging, which means that a lot of the work I was doing prior to COVID and long-term care was with recreation and leisure team members, was with the activation staff. Could be called different things at your home. I've heard cruise directors, fund directors, recreation, leisure folks, but really looking to see, most of the programming around arts was typically happening in the recreation world. And of course, when COVID happened, all of those large group programmings, those singing, things that were particularly dangerous for spreading the virus were pulled back. And so we were interested in learning from colleagues across the country, what was that experience like? And then actually gathering some best practices that we could then be shared. And we were able to publish these and present these at Therapeutic Recreation Ontario Conference, for example. So we had almost 300 people working in long-term care. So you can imagine, this is early on in the pandemic. I sent out my survey. I thought maybe I'll get a few responses. And we had almost 300 people from all across the country who said, I need you to hear what's happening. And people wrote a lot. Maybe some of you are on the call. I'd take the response from the little Excel spreadsheet that we get and put it into a Word. And some people would write half a page, 3/4 of a page, single space. They needed us to understand what was happening and to bear witness to their experience. We then looked through the data because we were seeing these feelings, as Jane had said, of shame, of guilt, things that seemed outside of what one would necessarily anticipate or expect to be gathering, stress, lack of time, of course, as you're trying to program in small groups or even individually, doorways, hallways, things like that. But these feelings of shame, guilt, distress kept coming up over and over again. And when we actually looked at the data, we found that even if we take a very broad view at it, about a quarter of our participants were experiencing what we would have qualified as moral distress. And these were related to staff shortages, barriers to implementing programming, failing to meet expectations. Folks who work in this space have very high expectations and they want to live up to those expectations. And often the expectations are self-imposed. Sometimes they're also, of course, coming from leadership or colleagues. But a lot of the times, as Jane mentioned, you're in this workplace because you're so drawn to serve. You're so drawn to connect and to work with residents. We were getting feelings of stress, guilt, worry, fatigue. And this all helps to paint a picture for us of sort of what is happening in a very unique way. What's happening in this space? We saw themes around individuals' mental health, struggling with mental health, lack of support for mental health. It's Psychology Month here in Ontario. Most psychological care in Ontario is not covered under OHIP, right? So people were experiencing these challenges with their mental health, but it was very difficult for them to access care. This feeling of guilt that I'm not doing enough either at work or at home. Guilt that now, because my kids are at home on virtual learning, I actually have to try and do my rec role from my basement with my kids there, and I'm not doing what I want to do for my residents. Inability to connect residents with families, right? Those early days where people were decorating windows and residents were trying to have, 15, 20-minute conversations on an iPad. Maybe you had one or two iPads. The Wi-Fi signal was crummy. You were running back and forth. You were trying to talk to people through your mask, through your face shield. It was so difficult. And of course, one thing that I think is really missing from the conversation, and I alluded to earlier, the media representation, is that prior to COVID, we knew from a large body of research that quite a bit of the care that occurs in long-term care is supported by family and friend care partners who are in that home, sometimes on a monthly, sometimes on a weekly, sometimes on a daily basis. Those individuals were removed. And that inability to connect residents, if a resident's partner is coming in every day and now you just don't have capacity to help them see their wife every day, that then causes that distress. And feelings of just trying to disconnect from work, trying to go home and, take some time off. We all hear about, self-care, but it was really difficult, if not nearly impossible to do, especially in those very early days when we were gathering those data. People were saying, I feel like I am burning out. I'm constantly worrying about my residents and how this past year has affected them psychosocially, right? Of course, we were very focused on the physical health and well-being of our residents, but there are so many other domains of well-being, the spiritual care that they needed, the emotional and social connections that they needed that were being restricted from them. Guilt about the sheer volume of residents that some just go without contact, There's only maybe one or two folks and you're running around trying to do your best and there's just not enough people to go around. Families, so worrying about, families calling in saying, I need to talk to mom, feeling like I'm not doing enough for my residents. Someone even used the term moral distress. Residents have limited family visits and they are lonely, right? We hear so much in the media about loneliness as an epidemic and we need to be engaging people socially, but staff working in these homes were being, just spread too thin and being restricted from providing that social care to folks. And being so burnt out from home makes it hard to want to be present at home. You come home from your shift and now you can't really connect with your family. You just need to zone out, maybe watch something silly on TV or just go right to bed because you just are so drained and exhausted. And it's a vicious cycle for folks, right? You're trying to hold on to that kernel of goodness. You're trying to remember why you got into this and why this is happening. But these can have impacts on your job satisfaction, on your own personal health and well-being, above and beyond COVID, just the physical strain on a person's body, the mental toll of stress on the brain, the social interactions. People were reporting, I don't want to see my friends after work, even at a distance, because what if I got sick from them and then I brought it back to my residents? That strong connection to your role, to your coworkers, to your residents, not understanding, how you can maintain this in such a heavily, such a time with such a high level of oversight on the work that you were doing. And really, how can we ask people to do more in that space? But I do want to say, I'm not trying to be the Debbie Downer. I think it's also really important for us to focus on where our strengths are and where we can find that hope. And you'll hear the word hope later on in the talk. But one of the things we asked people about in the survey we had provided, we had, as I mentioned, 299 responses. We said, what is something you're proud about during this time? I mean, you have done superhuman work. What are you proud about? And people really, thank goodness, they were not shy. They were extolling their own virtues, which I appreciated. You know, they said, one person said, you learn about this in school, and then you get to really live it, this experience. A number of people said over and over again, you know, if I wasn't sure about my career path before, COVID actually solidified that for me, that this is where I'm meant to be. These are the people I am meant to be with. These are the people I'm meant to be providing care to, but also deriving my own connections with. People, you know, I don't know if we still want to say the word resilient. We've heard that a billion times over the last 5 years, but people really were incredibly resilient, so flexible in what they needed to do. Team members were, you know, talking about going to the dollar store and buying 10 times of art kits so that every resident could have one when we were still worried about, you know, washing pens and crayons and things like that. Getting really creative with how programming was done, you know, outdoor programming that residents would see half the building from one balcony, one side, and then the musicians would go around to the other side so the other half of residents could watch. These are all things that are, you know, we're pushing ourselves, we're exploring new ways of providing care. Pride in one's strength, feeling optimistic because, as Jane mentioned, you know, this is a place that people are drawn to work, and these are individuals people are drawn to care for. And so drawing that sort of sense of hope, of purpose, of optimism from your residents. And of course, in these times when, you know, I would argue individuals living in long-term care and those in acute care settings were the most socially isolated people in all of our country. And yet our team members were able to be there, to be present with them, to provide that social connection with them. And that really helped people to feel like they were absolutely making an incredibly positive difference in people's lives.
Mhm. Thanks, Kate. So during the pandemic, I was supporting spiritual care in long-term care and working in a retirement home myself a couple of days a week. And I was also doing research with other spiritual care providers in their settings in long-term care. So out of all that experience, all that conversation, I wrote a paper that's cited at the bottom here called Supporting Spirits in Changing Circumstances, Pandemic Lessons for Long-Term Care and Retirement Homes. So what I found through that research was that spiritual care providers, as Kate said, were being very creative and creatively adapting the care that they provide to the pandemic restrictions. But they were finding it really challenging to meet needs for touch, for community and connection, for mental health stresses, and for processing grief. The importance of the spiritual care role became really obvious during this time as a listening and supportive presence for team and for family reassurance, as well as for residents. We learned during that time the value of smaller and more intimate gatherings of people. We learned to use technology better. But we also learned about the importance of ongoing long-term relationships between team members, particularly spiritual care providers and their residents and their families and their fellow team members as well. A common theme across all the spiritual care providers that I heard from was the increase in support that was needed by the team. Spiritual care providers saw how distressing it was for team members to witness the deaths of residents that they knew and that they loved without their families being present with them. And in so many ways that Kate's already talked about, they couldn't do what they felt called to do for residents and families. And of course, besides their work, they're carrying the family stresses and fears of spreading the virus. So team members during this time grew an appreciation for what their spiritual care providers brought to the home. Uplifting, inspirational, encouraging messages, hope posted around the home, or poetry and prayers in the newsletter that people could benefit from. Support with processing grief through rituals, resources, and most importantly, again, presence. Somebody that they knew was there to listen, to care, to lend a helping hand, a supportive presence for everybody.
So during this time, Jane and I were conducting research rather separately, you know, continuing to have those team meetings virtually, and I had heard Jane give a talk about her work in sort of mid 2021. And then around Remembrance Day, I was listening to CBC radio, and there was a segment with General Romeo Dallaire speaking about PTSD in Canadian Armed Forces members. And a voice that I recognize from graduate school speaking about this idea of moral distress. And it was Dr. Margaret McKinnon, who was at McMaster University in Homewood. And she was speaking about these feelings of shame and guilt and disconnection and confusion, and you know, where people are trying to find that hope in their work. And it turned out, I spoke with Jane about it. She'd been listening to the same segment. So we thought, oh, well, there's other folks out there doing this type of work. And so we actually reached out to Dr. McKinnon and her colleagues at McMaster, and began to connect with them around, okay, so this is present, this is happening. We're seeing it in our research, they're seeing it in their research. How can we actually come together and start to address this? Because it's not enough to just identify it and help put a name to it. We actually have to see what's out there that we can provide as resources potentially. You know, the CLRI and the RIA, we love to provide resources. You'll hear about that a little bit more later. But what can we do to take the learnings from our work clinically and from a research perspective to actually bring out and cast a wider net to hopefully help other individuals? And a graduate student at the University of Waterloo, Erica McTavish, and I conducted a scoping review of the literature to see what has been published out there around the interventions specific to moral distress in a long-term care space. There have been many interventions proposed in a lot of different care settings, but long-term care was really quite specific. And so we found a total of 7 papers that have been published. And, you know, they were the Dementia Isolation Toolkit, some of you may have used out of Baycrest, Digital Ethics Reflection Tool, a lot about ethics and spiritual care providers being interconnected with this as well, which is why it was so perfect for Jane and I to collaborate, moral case deliberation. But a lot of these projects that sometimes happens in the research world, where a researcher coming in with resources and funding to backfill people to be part of the projects, and then an 8-week intervention that would then be removed once the research project was over. And so we really became quite concerned about the fact that some toolkits, of course, would be left behind, but things like a moral case deliberation once a week with your manager may not actually be something that everyone could do. It may not actually be a sustainable approach, it may not be the most realistic approach. And then, you know, questioning for ourselves, where's this information coming from? Is this actually being led sort of from the ground up by the needs of the people who are using this? Or is this something that researchers are coming up with on their own and then bringing into the space? And of course, that can still be extremely useful. But we have such a strong spirit of co-design at the RIA, and really ensuring that the knowledge users are the ones who are helping to lead the work with us, that was something we were really starting to question, like, who is developing this? And so this was sort of the first step to seeing how can we actually bring people together and help. So really looking at how can we co-design interventions. We had a frontline expert on our team, Jane. Margaret McKinnon was also providing frontline care, so that was incredible to have her perspective on that as well. And we very early on decided as well that, you know, we didn't really necessarily want to focus on, of course, we needed to gather data around prevalence rates and, you know, how many people are experiencing this, but looking to see, okay, so we know this information, we know the statistics about what is occurring, what can we do next? And as Jane said so beautifully at the beginning of the talk, what does moral distress and moral injury actually tell us about the people doing this work? So how can we come to a space of moral healing? How can we help to develop and support moral strength? We have a big issue with staff retention in our workplace. So how can we perhaps use moral healing, moral strength interventions around that space to really help to support people and ensure that they are able to remain in their workplace, which they have been drawn to for a reason. So we called together a think tank of individuals that about 40 people came to the RIA up in Waterloo in September of 2023. We had people right from across Canada. We had people from organizations such as the Ontario Long-Term Care Association, folks from the CLRIs were there, and researchers and also clinicians from across the country. And we're, the timing of our webinar is purposeful because we have just launched the report from this think tank, but we also have a great website that will be popped in the chat, and you can go and take a look at all of the resources that are available. All the slides are up there from the folks who gave talks. We had sort of a very rapid presentation of lectures in the morning, 10 to 15 minutes. Many people were able to share their data very quickly. And then in the afternoon, we sat together in roundtable discussions and ideated a little bit about, okay, this is what we're all seeing. This is happening over and over again across the country. Where can we go next? And as Katrina mentioned, this is the first time in Canada, to our knowledge, that such a think tank has been pulled together. So we were really quite delighted that so many people were able to attend. And we, of course, that was September 2023, which is a long time ago now. But some of the things that we were thinking of in terms of outcomes for our think tank were this idea that, of course, we as individuals can try and make change. We really need all of us together to advocate and push for system level changes where we are able. So if a large issue here is staffing levels and hours of care, that's something that needs to change at a system level from the top down. Making sure we have that management and that leadership support for our frontline staff, our point of care workers. We heard a lot about peer support. And of course, this is happening naturally, on breaks or as people are walking out to the car together, but trying to make it a little bit more purposeful and have those sort of protected spaces and times, whether it's in a huddle, whether it's in a session, after lunch, bring a cup of coffee together and sit together and talk about these experiences. And making sure, of course, that we're creating and nurturing relationships between team members and residents, and including our essential family and friend care partners. So although our research is looking at more of what used to be called quote unquote formal care partners, so those staff or team members, point of care, frontline workers, we also know, of course, that these types of experiences were also occurring in our family and friend care partners, who weren't even able to be in the homes, and we're now relying on a third party to try and reach them if possible, if the Wi-Fi was working, if the iPad had battery. So there, of course, needs to be an inclusion of those individuals too in their perspectives, and making sure that we're addressing wellness needs through accessible supports and resources that can be provided either through the home, care within the community, leadership supports, and making sure that people are aware of this. Here's a picture of our report. You're welcome to download it. I think the website was just popped in the chat there. So if you'd like to have something to look over, maybe tomorrow at lunchtime, you can take a look through. We talk a little bit about the protocol and the procedure for the day and some of the incredible learnings that we gathered from our colleagues.
So after the think tank, we continue to have regular meetings of those people who are at the think tank to connect with each other, to share learnings, continued learnings from our own work across the country. But Kate and I wanted to actually do something more and keep working on this locally. So we thought it's so important to have more conversation with team members in long-term care. We wanted to see if what researchers were talking about made sense to you on the front line in long-term care, and to keep listening to the experiences post-pandemic, and to figure out together what will be helpful going forward. So what we decided to do was take these, and you can see here the illustrated board, one of the two illustrated boards that were created during the think tank. We took these boards to one long-term care home, and during break time, we invited team members to come and see them and to talk with us and to fill out a survey. So we have 53 team members come for their break with us. And these are some of the questions that they answered for us. What do you love about your work? When do you feel really good about the work that you do? Take a look at the illustrations. See what stands out. What are your favorite parts? What would you add to illustrate your experience? And we asked questions about moral distress to find out if they knew what it was and what kind of experience they had had with it. Finally, we asked questions about what supports your mental health at work and what strategies do you use to find hope in your work. What we heard clearly echoed the conversations that we had been part of at the think tank. So we learned that mental health and hope at work are supported by personal efforts at work, away from work, team connection, and resident relationships. So let me say a little bit about each. Their own personal efforts at work included things like routines, positive attitudes, including humor and patience, respect, enthusiasm, and a readiness to learn and contribute. They talked about personal efforts away from work, like self-care, exercise, spirituality, relationships, counseling. Team connection was important. Coordination, collaboration, and commiserating, lots of C words. Supportive group learning and discussions, and supervisory relationships were all identified as really important. And perhaps most striking, and again, echoing what we heard from the think tank, relationship with residents. Connecting, seeing things from their perspective, wanting to help. One person who came and spoke with us said, after major surgery, I came back to work quickly because it helped me to be at work, taking care of my residents. So what contributes to feeling good about work? You see echoes again here. It's about having capacity, being well rested, nourished, ready to come to work. It's about work being meaningful and rewarding. So many said that it's a privilege to do work that matters, to have the opportunity to serve. So you see the strong morals and values in our workers here. The sense of satisfaction in doing work well, rising to challenges, and being able to go beyond and do the little things. Being part of a team, belonging, collaborating, being supported and acknowledged. And again, those reciprocal relationships with residents makes people feel good about work, knowing and being known, seeing smiles, hearing stories, being trusted, and even accompanying someone to the end. All of these things contribute to people feeling good about their work, but sometimes they don't feel good. They experience moral distress. And when they were telling us about what that's like and what they do, team members said to us that they confide in trusted others, whether that be colleagues at work or people at home. They lean on and strategize with their teams. They seek information, they want to learn, and they try to relax and decompress, usually after work, sometimes in the moment if they're able. Those were positive responses to moral distress, trying to get through it in positive ways. We also heard some things that were more negative. Some people saying, well, we just survive, we make the best of it, get the job done. And others said, I feel bad, I separate from feeling, retract into myself, I stop contributing.
So thank you, Jane. What we're going to be doing with this work is continuing to push for a co-design model. So using what has been shared with us by these team members. And I should note, when Jane and I applied to do this research in this one particular long-term care home, we have a formal process that we go through to ensure that residents and team members aren't being asked to do too much research all at the same time. We had said that our potential number of contacts would be 20 team members. And we thought, okay, that'll be, maybe we'll get to 20. And we sat in the chapel of this space. We had cookies and coffee, which can always help to attract people to your survey. But Jane also would go up into the neighborhood units and connect with team members there and, remind them about the study. But we had over 50 people come and speak to us. And it's very important to us that we take everything that people shared, because people really did share quite deeply with us what has been going on with them. It's quite important for us that we continue to take this knowledge and use it in a really productive and powerful way. And so this is why we're here with the CLRI, because the CLRI team, with the reach across the province, can actually help us then to take our learnings from a research and clinical perspective and help to turn it into educational resources that leadership can use, into posters, flyers, digital media that can be used in homes to really reach out to team members and help them feel better in their work. And also just, I think a lot of people coming in just felt better that they weren't alone. It was just nice to come and talk about what had happened. And a lot of people, of course, are not just experiencing struggles at work these days, right? Life is very expensive. People were also having a lot of struggles outside of the workplace. And while that cannot necessarily be part of the particular work that we're doing, it's also important to place people's distress in the context and help to use those data perhaps to, again, advocate for change. Yes, cookies and coffee go a long way. We did have to resupply our cookies because a lot of the residents also wanted to have cookies. And so they went quick, to be fair. We had to go out on a cookie run. And then I also wanted to just touch on another piece of work that we've done. So this is in collaboration with teams from McMaster and Trent University, who generously included us in the research they were already doing in acute care, and with a number of other groups that were particularly impacted by COVID. So people working within, first responders, people working in funeral homes, and they allowed us to expand our reach out to folks working in long-term care. Again, maybe some of you on the call had done this research study, but some really important things that we felt we can then weave back into the research and really connect to what we've talked about here are findings of, and these are of course only correlational data, so we can only draw connections. We can't say, with proof, this causes that to occur. But what we can see from this data of almost 100 participants is that those individuals who indicate higher levels of social support in the workplace, within their family friend systems, they tend to have better quality of life, better quality of work, and higher levels of hope. And then in turn, that higher level of hope does seem to connect to lower levels of PTSD and lower levels of moral injury on self-report questionnaires. So these are really key pieces that we can tie into. And something I think Jane had mentioned earlier that is so unique about the work that we are doing here at the RIA is this focus on the resident relationship. Most of the research, I would argue, in long-term care tends to talk about, especially from a staffing, recruitment, retention, return perspective, tends to focus on colleague-to-colleague collaboration and leadership-to frontline team member collaboration. There is not as much focus on what are the strengths that are actually drawn from those relationships with our residents, from having that time to just sit down with a resident, or maybe their grandkid comes to visit and you see them grow up, because a lot of our residents are in our homes for a long time. Residents know us, residents care for us. It's such a bi-directional relationship. And that really emotional intimacy, that occupational intimacy that you don't see necessarily in primary care, in an acute care setting, even in a rehab type of setting, it's really quite unique to the long-term care and retirement space. And so that's something that we really want to hold on to. Within our organization, the Schlegel Villages, we spend a lot of time getting to know our residents. But now there's a lot of push within the operational supports of the organization to sort of expand that even further for the residents to get to know the people on their team, right? And we very purposely call them team members, not staff, because it's all part of a team. And so, we have a questionnaire for residents when they come in. What about a questionnaire for team members that then gets shared with residents? So about your residents' background, about, their family history, things like that. And so you can even see that relational care approach strengthened, because not only are we learning, from resident to team member, but also from team member to resident. So this is all some of the work that we will be bringing in, and we'll tell you a little bit about as we wrap up. And I should just mention, Healthcare Salute is an incredible website that has been created by this collaborative team. And you can go, it was a very long URL, so I didn't put it here, but we can pop it in the chat for you, and you can go take a look. There are beautiful, beautiful resources that have been created through that website. And it's in both English and French languages as well.
Well, Kate's segueing us very well into the next thing we wanted to talk about, which is some strategies for supporting work in long-term care so it can be truly good, even when it's hard. So many of these things, again, will feel like echoes and perhaps things that Kate has already hinted at here, but structural and institutional changes. So there's four different levels of support and strategies that we can talk about: structural and institutional, home level, supports for team members, and then those connections between residents and team members. So structural and institutional changes. of course, these things might be beyond the scope of researchers or even leadership teams in our long-term care homes. But as researchers, we know we can share the data that we gather as means of advocating for widespread improvements in the long-term care sector. And there are hopeful changes that are happening and on their way. The goal of 4 hours of direct care coming this spring, that's hopeful. We can see change on the horizon that we can live into and use. At the home level, we can create opportunities for community building, fun and meaningful events, everything from a chili cook-off to celebration of life services, things that we do intentionally together to build community, build that kind of place where that's really life-giving for everybody, whether resident or worker or family. We can ensure times and places to support one another as team members. Peer support practices, maybe peer support groups, places that normalize asking about and sharing experiences and feelings in an environment that we know to be safe, to be supportive, that's there for us as part of the community. And it might be as simple as providing a coffee machine in an area that invites people to refuel and connect, or the occasional shared meal that's provided for people. All those things that can help us to build community and refuel in a supportive way. And we can think about how we support team members at different stages along their journey through recruitment, onboarding, and ongoing as they work at a home for years. We can talk about the realities of moral distress and moral injury at onboarding, at leadership training, giving people the vocabulary to know what these feelings might be and why we have them. We can create recruitment resources that highlight the richness of work in long-term care, that can hold up that goodness and the importance of this meaningful work for our society. And we could maybe create inspirational posters or videos to be shared with all team members, using words from our research, from talking with team members, so that we can encourage learning from colleagues, feeling heard and valued, and being equipped by each other's wisdom and strategies for coping with and living into this kind of work. We could also train EAP providers, the counselors that you can connect with, to better understand working in long-term care, the current realities of the long-term care system, what might make moral distress and moral injury unique to staff in long-term care, so that when you go for counseling, a counselor actually gets it, has a bit of understanding. And finally, fostering connections between residents and team members. As Kate mentioned, there's lots of opportunity for this. And if we have more time to be with residents and dedicated care relationships, we can continue to encourage and facilitate and give permission for all employees to connect with residents and with their family members and build those one-on-one relationships, and also participate in village events together to keep building that community. And also, so that's the fun part of it, community building events, but also to be with each other through the hard times and the sadness, and to recognize the grief, to have celebration of life events, those kinds of things, that there's the joy and the sorrow that we're all in this together with. And Kate also mentioned the possibility of highlighting specific residents and specific team members so that they can be better known to each other. Perhaps a display area in the home where we could have a team member of the week who could bring in photos or special things for residents and their families and their fellow team members to get to know them better. And same as we do for residents. Lots of different ways that we can get to know each other and build those relationships in that community that supports the goodness of the work environment.
Thank you, Jane. So we also wanted to just talk about, we're thinking a lot about the future and what we can do. But for those of you here on the call today who are working in the space, perhaps you're, taking on a leadership role at your home, there are easy ways to integrate a lot of this into practice right now. Food helps. Some people said, it would be really nice to have a free pot of coffee for team members. It's always nice to have, especially on these cold days, just a nice cup of hot tea or hot coffee to have. But raising awareness, maybe you want to take some of the learnings from this, and feel free to use our slides out into your home and have, your own webinar, your own lunch and learn, maybe something at a team huddle. Holding space for all emotions. So making sure people understand that these feelings of shame and guilt that are so common, are not something to shy away from, are not something to feel alone in. This is happening, across the sector. Sharing the experiences, helping to deconstruct ethical dilemmas. We do this every year with my college. We always have like a tricky ethical issues day, and it often leaves you with more questions than answers, because sometimes there is no right answer. Sometimes you just need to be in that space together and just discuss and look at all the different possible answers. Trying to see whether there's ways of accessing care, of taking a little bit of time away for yourself, and adaptive coping methods. So with my arts and aging hat, a lot of the work that we've been speaking about today has been funded through a large grant that I do have through the federal government, from the Natural Sciences and Engineering Research Council of Canada, that has been providing funding to us. And so we have a particular focus on using the arts and arts-based programming to help us in this work, in helping us to come together and heal. So ways to get involved. Perfect segue to my own research. So I noticed one of you on the line is already aware of this research opportunity, but I'd like for you, and you can take your phone if you have one, or we can also maybe get that. Sorry, Katrina and Sarah, we can get that link and pop it in the chat. We have a survey that's open right now where we're asking people to tell us a little bit about what type of creative opportunities they have within their workplaces. And what we're actually doing is we're looking for 100 long-term care homes across Ontario who would be willing to be sent an art making kit. So it'll be full of a lot of different resources that, again, we have co-created this kit based on data from other homes. And you will be asked these questions too. And these kits can be used to solidify those relationships with residents. They may be used during team member huddles or team member retreats. And we'll send these to you and we'll follow you for 3 months. So we'll ask you to do a number of different surveys at different touch points at 1 month after you receive it, 3 months after you receive it, and let us know whether having that opportunity, sometimes just sitting down across from someone and chatting is more difficult, but it can be made easier if you have a shared purpose and a shared creative path within that discussion. So this is the particular study that we're looking for. We're calling for 100 creative champions across Ontario who will help us to work on this. It's only available in Ontario for folks working in long-term care at this time, yes. And then because we are here with the Ontario CLRI at the Research Institute for Aging at the Waterloo, we're looking for people who will help us co-design some of these opportunities. So weaving in the research that Jane and I have been speaking about today into very purposeful, practical, educational tools, accessible resources that you can use within your own homes to share some of these learnings today. So again, kind of being the, gathering all this information and then being the champions within your own home. And we have a form here that you can sign up for. So 2 opportunities to sign up. And this will be to specifically work with the Ontario CLRIs to help co-design resources that can be shared, of course, here in Ontario, but really right across the country, absolutely.
We have our contact information here for you as well, and we want to take some time for some comments, questions, conversation. We just have about 5 minutes, but that's time for a little bit, and hopefully Katrina and Sarah can feed anything that's coming through the chat. Perhaps I should stop sharing so that we can see any hands raised as well here. Perhaps you have ideas or initiatives that you're implementing in your own setting that you'd like to share connected with this topic. Anything anybody would like to bring up? Or Katrina and Sarah, I don't know if there's been anything in the chat.
Yeah, we had a few questions in the chat that Kate's been responding to. There was a question about if your research has been expanded into retirement homes, and Kate clarified that right now there's funding specific to long-term care, but the hope is to do that in the future. But yeah, any other questions from the group or anything else anybody would like to share? Bryce, I see
I'll
you
ask.
muted. Go ahead.
Yeah, sorry, I apologize for joining a bit late. And I feel I work in a very supportive environment, and I'm hopeful that our team members see it that way. I think based on the employee engagement survey results, they do. But I was just wondering if you touched on in this webinar just the early signs of moral distress in team members so we can all be more proactive. And if not, can you give us some ideas in that regard? Early signs of moral distress, Kate or Jane?
You want to jump in, Kate?
Yeah, I mean, that is a great question. I think, moral distress is not that different from other forms of distress. It's just where the soul injury is occurring. So it's, people can be feeling like they're getting very stressed. They feel like they don't have enough time. Maybe they're starting to feel anxious about not being able to meet the needs of residents. So in terms of sort of early warning signs, I would say conversations you're having with your team members, use this type of language. Are there things that you feel you're not able to do that you're called to do, but there are restrictions happening? And it could be restrictions from staffing shortages on that day or ministry barriers that we're encountering. So having those conversations with team members, and I'm sure at your village you're having those already, but really starting to have those conversations with them, and maybe having a, like perhaps when we develop these resources, moral injury and moral distress definitions in the village offered with onboarding. So people sort of know what these feelings can feel like and what they may actually be experiencing. I see here someone has asked something similarly in terms of like, are there differences in terms of the signs or experiences or needs or expressions emerging between the different groups? So personally, I have mostly been focusing on the life enrichment group. I know that there has been some research being done more so in the acute care space with RNs and RPNs, but I don't know, personally, we haven't really had, divisions within our own research, but the McMaster team, in addition to the survey results that I mentioned, they also collected interviews with a variety of different roles working within long-term care. And I believe that, they did touch upon perhaps differences that were being experienced. Because in particular, if you think of someone who's providing, for example, like a PSW individual who's providing more of that personal care, there was a lot of fear because they are so up close and personal with the resident, and there's such a physical closeness that they are experiencing and that they have to, right, in order to be able to help someone bathe or help someone get changed from clothes into pajamas. So that's absolutely something that those qualitative data will be able to suss out a little bit more, but we don't necessarily have results on that yet. And I see, Deborah, that there is no current one-pager explaining the Creative Champion study, but I can absolutely make that. And perhaps we can have that with the CLRI team. We can have that shared with you to explain a little bit more exactly if you want to take that back to your team to explain what that will be about. But these are some great questions. And I would just say, I think, the answer I gave is a little bit of a no answer, where like we don't really have specific warning signs or symptoms because this isn't something that's being studied proactively. Most of the research that we're doing right now is retroactive. So we're asking people to think back and comment on their experiences. It's really hard to then kind of tease out what were the things that maybe were those early warning signs. But that is an incredible way, of maybe facilitating conversations with leadership to say, like, just be aware that this might be happening and your team member may be starting to experience this.
I see that we're at 1 o'clock, and I'm thinking of early warning signs as being things like frustration, of just not being able to live into who we know we really are. And so we might hear those rumblings of frustration as a first sign. But as we close, I do want to thank each of you, for joining us today. We hope that you're leaving with a sense of encouragement and of affirmation that the work that you do is so valuable and so meaningful. And we hope you go with assurance that we can keep working together to create environments that are both homes and workplaces where you can thrive together in mutually supportive communities. And we hope that you go knowing that in these communities that are at once heartbreaking and joy-filled, you can give your all and you can receive the reward of doing truly good work that's life-giving, not only for those you care for, but for yourself and for your team. So thank you for all that you do, and thank you for joining us today.
Thank you, everyone. Thanks to the CLRI team for putting this on. This is a massive undertaking, I know, to get us all organized on the same day with all the presentations. And thank you very much. It's been lovely to work with you as well. Thanks everyone for your comments. We appreciated having you here. And the recordings will be available with the CLRI. So in case you want to share it with someone within your organization too.